Maninder, can you check with Dr. Ichapuria, please?
Yeah. I just called him. He's just joining in 3 to 5 minutes.
Perfect.
At least we can complete, then we can start on time, and then maybe sir can join. We can
start
on the time, no, sir?
Yeah, we should start. Yeah. Dr. Jaraj, it's okay, right?
Yeah, we can start on time.
Thank you, sir. RX Events, please confirm if we are recording and live. All right, sir. Thank you. Gerard, sir, if you permit, with your permission, sir, can I start the event?
Yeah, sure. Yeah.
Thank you, sir. So good evening, everyone. I am Dr. Sanket Nibale, representing Medical Affairs at Emcure Pharmaceuticals. Today, we have gathered here for discussing on it and listening from the eminent speakers and eminent practitioners in neurology, stroke specialists on the evolving global landscape in the management of acute ischemic stroke. We are witnessing a pandemic, and we are looking out, the entire healthcare system is looking out for directions for the best outcomes of their patients. So with that, I would like to invite our today's faculties. We have our esteemed moderator and speaker, Dr. Jairaj Pandian, sir. Sir is a principal and professor of neurology, Christian Medical College, Ludhiana, Punjab. Sir is a vice president, World Stroke Organization, president, Indian Stroke Association, chair of Asian Stroke Advisory Panel, awards and publications. He's a recipient of the Global Stroke Services Award 2020 by World Stroke Organization. He is the first Asian to receive this prestigious award. Congress co-chair, World Stroke Congress 2016 at Hyderabad, published widely on stroke thrombolysis, stroke systems of care, epidemiology, and rehabilitation in low and middle income countries. Publications total of 211, citations of 102,431 with an H index of 54 and I-10 index of 109. He is a national principal investigator for Indian Stroke Clinical Trial Network, and he has a special interest in stroke care services, stroke trials, and systems of care. Sir, we welcome you for the event.
Thank you very much.
We have Dr. Ichapuria, sir, who is our esteemed panelist. Sir is a director neurology at Sahyadri Hospital, Pune. He is the first neuro ICU, and he has started neuro-intensive care at Pune. He has been a pioneer in thrombolysis treatment for stroke in India, with more than 300 public lectures and workshops on stroke. He is a member of the Indian Stroke Association and organizing president of StrokeCon 2012, the organizing president of the ISA Stroke School. He is an ex-president of the Society of Neurosciences, Pune, and an ex-president of Maharashtra Academy of Neurology and founder of the Pune Stroke Group. He has been the principal investigator for multinational stroke trials like PERFORM, BG12, cortical venous thrombosis, BrainSkate, Interact2. Recently, he has been awarded as a health icon by the Times of India Group. Sir, we welcome you for the event. We have Dr. Gigi Kurtukulam, sir, who is an esteemed panelist, and he is the head of an interventional cardiologist, neurologist, Department of Neurology, Lakeshore Hospital, Kochi. He's the first interventional neurologist in Kerala. He has association and membership of American Academy of Neurology, Society of Vascular and Interventional Neurology, USA, Neurology Society of India, Indian Academy of Neurology, Kerala Association of Neurologists, Interventional Neurology subsection in the Indian Academy of Neurology, Interventional Neurology subsection of the Indian Stroke Organization. Sir, we welcome you for the event. We have our esteemed panelist, Dr. Arvind Sharma, sir, who is head Department of Neurology, senior consultant neurologist, stroke specialist, and neurosonologist at Zydus Hospitals, Ahmedabad. He is Honorary Associate Professor of Neurology at BJ Medical College and Civil Hospital, Ahmedabad, Secretary of the Indian Stroke Association, President of ANBAI, Gujarat, Founder, Member, and Treasurer, Society of Neurosonology, Executive Member of Academy of Neurologists of Ahmedabad. He is the Executive Member and Treasurer of Indian Stroke Association 2018 to 2020. Publications in national and international journals in peer-reviewed scientific journals. He has won the Best Poster Award at AOCCN in April 2009 at Seoul, South Korea. McKinney Award at American Society of Neurology 2011 at US, Florida. Travel Award at Asia Pacific Stroke Conference 2012 in Tokyo, Japan. Travel Award at European Stroke Organization 2018 at Gothenburg, Sweden. Sir, we welcome you for the event. Now, I would like to hand over the session to our speaker, Dr. Jairaj Pandian, sir. Over to you, sir.
Yeah, thank you, Dr. Sanket Nevale. And I'll just share my slides. So, good evening, everyone. And what I'm going to do is give an overview of stroke care during the COVID time, and particularly in the hyperacute phase, and what are the recent advances, particularly in relation to Tenectase and its applicability in the current situation, and also in the coming couple of years, what is going to be the advances in terms of acute thrombolysis, intravenous thrombolysis. So stroke statistics, we know that low and middle income countries has a very high incidence of stroke, and based on the many GBD data, there is a 40% decline in stroke in high income countries. However, there's almost 100% increase in stroke incidence in LMICs. The stroke prevalence in India, it ranges from 147 to 922, and incidence is between 119 to 205 per 1 lakh population. So according to the estimates, we have about 1.8 million new strokes every year. And if you look at the global phenomena, 70% of strokes occur in LMICs. More than 87% of their disability adjusted life years lost due to stroke is in LMICs. Another important difference that we all know is the average age of stroke patients is less, about 15 years less as compared to high-income countries. So, we all saw how the stroke systems of care was affected in wave 1 and wave 2, and how the many healthcare systems adapted. In the first wave, the most dramatic thing that we saw was a decline in number of cases for a few months, a decline in IVT, decline in mechanical thrombectomy, and slowly, the health systems adapted, made a lot of changes, internal changes, and then the numbers increased. But it has still not reached that pre-COVID level. And in the second wave, also there was sudden decline in number of stroke patients, but this time people were well prepared, and at least the stroke patients and relatives had some confidence to come to the hospital, unlike the first wave. So the differences in stroke systems of care in LMICs is that already the healthcare system is fragmented and overloaded with COVID patients. They had a lot of difficulty in adapting and continuing the services for stroke patients. And in addition, there is a rural and urban healthcare divide that we all know, and there are less neurologists in LMICs. So if you look at the stroke systems of care, you have the pre-hospital care, and then in-hospital management, the emergency department, the various protocols and imaging, stroke unit, and then the secondary prevention, rehabilitation, and follow-up, and telestroke. I'll just quickly touch upon the challenges that people faced in the pre-hospital care and in the entire stroke continuum of care because of COVID. Many ambulance services were diverted for bringing COVID patient. Lack of PPEs, stroke was not a priority in many LMICs. And many hospitals did not have this protected stroke code, even though there were guidelines, particularly the Indian stroke guidelines we had released during the peak of the first wave. And imaging, the ideal situation is to have a dedicated CT for COVID patients and dedicated DSA angio suite for COVID patients, but that is not possible. So that is where a lot of centers had difficulties taking care of the prevention aspects of exposure to other people, particularly people who are working in the imaging area and the DSA lab. And the most important part is the beds that were with the stroke units have been taken away. And very few centers had this COVID designated areas where they shielded every area with the non-COVID, and they were able to focus. And soon the many hospitals started adapting, and rehabilitation was greatly affected, and so has the discharge plan. So in a situation like this is based on the WHO and ASAHA position statement that we released last year in November. So we know the ambulance system in our country is better. They reach the hospital with any modes of conveyance. And if the ambulance is there, they should use it. And protected stroke code is very important. And in all suspected COVID patients, they should take appropriate precautions and PPEs. Neuroimaging, yes, if there is a suspected patient, you need to have PPEs and a minimal staff, and after every scan, you need to sanitize the area. Excuse me. So IVT, better to give thrombolytic agents in the CT itself, and the TNK has emerged as an alternative option because of minimal exposure that people have. And in terms of thrombectomy, conscious sedation is preferred. If there has to be intubation, then it's better to do it in the ED and then bring the patient there. So stroke unit care, written protocols and the evidence-based protocol should be implemented, and in rehabilitation and follow-up, it's a telestroke. So early experience with TNK, this was published in December last year. This is probably a summary of both the experience from wave 1 and wave 2, but largely from second wave, where people, just shifted the agent, thrombolytic agent, in terms of convenience, and there is so that they could avoid exposure to staff. And so this is a very good paper which was published in Neurology Clinical Practice. So if you look at TNK, the global how it evolved in 2008, and then in 2010 we had the phase 2B and study, and it was not exactly dose finding, it was stopped in between. Then 2012 we had the important TNK and TPA comparison from Australia, and then a test, not test, at Extend IA. And these trials were looked at the bridging therapy comparing TNK versus TPA, and then in COVID period, and some recent meta-analysis. In summary, from the global trials, 0.25 milligram was superior to 0.9 milligram. The important thing is the convenience and the bolus instead of infusion with TPA. The safety profile was superior, and the most important finding in terms of large vessel occlusion is bridging component, where people who had received TNK had a higher recanalization rate as with the mechanical thrombectomy. And 0.4 and 0.25 was compared, but 0.25 has a better advantage. Overall, the early neurological improvement, that is within 24 hours, is higher as compared to TPA. And slowly, I'll just discuss some of the countries where they just change the practice and without any approval, and particularly in some stroke networks in Australia and New Zealand. So in the Indian scenario, we had this in 2018. It was approved even though the results were presented in the World Stroke Congress in Hyderabad in 2016, and the paper was published in 2018. It was an observation study. Unlike the RCTs, however, the DCJ had given the approval for this particular drug. And there are some retrospective data from India. There are some case series from India. And so currently approved dose for India is 0.2 milligram per kg. And from the observation study, there has been a better early major neurological improvement with TNK. And there are, from the retrospective case series from India published so far, one is the improvement, the functional outcome is almost similar, the hemorrhage rates are lower, and the cost is lower. And the recent ones, the Green Journal paper, the neurology clinical practice I mentioned, and how they, even though the FDA is not approved in US, but they switched practice. And one article on Get With the Guidelines recently published, and which shows a good proportion of stroke patients in US itself, they don't receive thrombolysis. And so that cohort could be an important cohort, whether at least TNK can be given or not. And the WSOHA is a position statement on COVID, which was published end of last year, and there are some papers from the IAC. So the in summary, I think that the Get With the Guidelines is here. Get With the Guidelines is a large quality program in US, and all the hospitals enroll themselves, and based on the quality performance indicators, they are rated, the hospitals are rated, and awards are given, and certification is given. And so the large data of about 39,000 stroke patients, and about almost close to 40% of these patients did not receive thrombolysis. And what happened to them? And you can look at here discharge location. About 44% of them were discharged home, and the rest were in nursing home or rehabilitation. The mortality rate was high, and readmission rate was high in this particular cohort. There is some recent literature from the IAC, from a multi-center registry. The symptomatic ICH rate is almost 50% less as compared to Alteplase. So what is in store for future? There are trials which are ongoing. I would just highlight some of the important trials, the TASTE2, TEST2, and the Canadian study should be ready, I think, maybe in the coming ESOC, or maybe in the next year IAC. And so these studies are looking at different categories of patients, the bridging therapy, then directly, comparing as a registry trial in Canada, in looking at 0.25 versus placebo from 4.5 to 24 hours. And so I think by middle of 23, most of these trials would have been completed, and in the year 23 or end of 22, we would have a clear direction how we are going to head. And so in summary, the Director of Health Services and the guidelines they have published, TNK is indicated approved between 0 to 3 hours, and 3 to 4.5 hours TPA. In other guidelines, and even though the level of evidence is lower, 0.25 is recommended. It is reasonable, and 0.4 has not been proven superior or non-inferior to alteplase, but can be considered as an alternative. But however, the European stroke guidelines currently recommends only for bridging therapy to use TNK. So with that, I'll conclude, and I will open up for a discussion. Maybe before I address an individual question, I would ask Dr. All the panelists to give their views, and then probably I will take up, I'll address some individual questions. So Dr. Gigi, just I want to know, can you tell us in a few bullet points, what is your experience with TNK?
Thank you, Jaraj. I see Tenectase as we have one more device or one more drug which is available with us, along with alteplase, to treat acute ischemic stroke. So it is found to be at least equally effective as alteplase. In our experience, especially I do interventions also, one of the distinct advantages, it can be given as a bolus, especially when a patient needs to be, a large vessel occlusion patient needs to be transferred from another center. It is much more easier to give as a bolus injection and then immediately transfer the patient to the higher center. One of the problem with a prolonged injection, 1 hour infusion, is naturally it will have to wait till that infusion is over. Transporting the patient or transferring the patient while the infusion is on becomes difficult. The bystanders are like, why not we wait till the infusion is over, then we'll see. All those delays are happening. So as far as from an interventional point of view, the patients with a large vessel occlusion, a bolus injection is definitely a distinct advantage. I don't see it as a competition, but we have one more drug to treat acute ischemic stroke. It can be, and it is as effective as the other drug. That is the main advantage which I see.
Yeah, Dr. Gigi, thank you very much. And Dr. Arvind, can you share your experience? Yeah.
No, thank you, Dr. Jaraj. And I endorse Dr. Gigi's point, right? So alternative should always be there for the one drug which has proven for the effective for the treatment from so long, since 1995. So if we found this drug, and it's definitely, if in the bridging is very effective, and there are a lot of trials which are coming in, as you have showed those chart which have showed all the trials, the timeless, and definitely we are discussing with Andrew about it in one of the Castle program. And answer will be, I think, 2022 in the ISC next, or before that in the World Stroke Organization, they will present their results. So we are waiting for that. So only thing that we should also match the doses, right? The doses which are discrepancy is there. That is the only question which arises. 0.4 definitely not seen very effective. It is the 0.25, and the Indian drug which has been used is 0.2. So it is very near to it, right? So I think more can be emphasized by Dr. Ichapuria.
Yeah. Thank you, Dr. Ichapuria. Thanks for joining, and I would like your comments about your.
Thank you, Dr. Jairaj.
Yeah.
I think most of the points have been covered very well. I find it to be equally effective, and I don't think there's any difference where we use 0.25. I don't think there's a significant difference, at least in the few patients that I've used it. And it's definitely more convenient. It has the advantage of the bolus only. So that's a distinct advantage. And the cost in our setting, because it's a biosimilar drug, is also less. So it has quite a few advantages over alteplase. The only thing that holds me back a little bit is that still the recommendation is 2B, na? Is it 2B? Yeah, it's 2B, and it is a biosimilar. It's not the originator molecule, so we don't have comparisons exactly with it. So that these are the few limitations in my mind. But having used it, I find that there is not much difference between TPA and Tenectase. So I'm comfortable with it, but I would like more detailed study and a little head-to-head comparison to give us more confidence in using it.
Yeah, so I think Dr. Arvind, you want to
I will answer that question with these trials. Those all the twist and the taste with the timeless zone will give the answer in all these trials, which names are there, right? In that ongoing trials. I think that will answer, because there is a lot of number of patients, 1,817 attached to taste 2, they are 1,124. They're huge number of patients. So people definitely will give us an answer. And especially waiting for that 9 hours window, right? If the bolus can be given and if it is approved, it will be very effective.
Yeah. So
just now in India, it's only approved up to 3 hours. We can't use it for up to 4.5.
Yeah, the 4.5, Pranav, with the current recommendation, it is riskier. If there is, of course, if you have an advanced imaging and if you're able to find out LVOS, we can presume that it works, but we need to have more evidence on that. Yeah. So to Dr. Gigi.
So that's holding us back a little bit.
Yeah.
We would like to use it in more patients because of its advantages. But these few little niggles, I think, have to be removed from our mind, till we have full confidence.
Yeah.
So that is my only it's a small reservation, but it's there.
Yeah. So there is a trial, Dr. Rohit Bhatt is the PI. It is in the INSTRUCT, Indian Stroke Clinical Trial Network. It's called Reopen, where within 4.5 hours, we are the people who are eligible for thrombectomy. We are comparing head-to-head biosimilar TNK versus alteplase, and so that the recruitment should begin in April. The sample size about 320. My feeling is that before we even touch 70 or 100 patients in that trial, the answer would be very, in terms of bridging, it'll be very clear. But the only unique thing in India is that we are comparing the biosimilar. And so that is one trial which is in pipeline and may take a couple of years to complete it. And so the one question I want to address to Dr. Gigi, see, when you're bridging them with TNK, and in terms of thrombectomy, when you do, technically, do you find it's easy to remove the clot with first pass, second pass, third pass? Is there any technical, I would say it is easy to remove, or is there anything, what is your experience on that?
In our experience, now we have done around almost 230 patients underwent thrombectomy. 3 patients who received TNK, the vessel had already opened when we did the angio. Second thing, now we couldn't find any significant difference because each patient is different. Some vessels open easily. So to say that whether it facilitated thrombectomy, it's a very difficult thing to answer. But now we had three cases now where definitely on CT angio, the vessel M1 was occluded. But when we took up for thrombectomy, the vessel had already opened. Yeah. And the main advantage is this can be given in the CT gantry itself. So like you give the shoot and then shift the patient for thrombectomy. So for me, it becomes a distinct advantage.
Yeah. So we had one of patients recently, young lady, and they were just deciding for thrombectomy, and finally they agreed for thrombolysis, and so we gave TNK, and then later on they agreed for thrombectomy, and with suction itself it just came out, and we didn't use the stent retriever, and so this is just one single case experience, but that's what I was interested, whether there's any technical challenges and issues if you face when you do bridging as compared to alteplase. And
no, already that study has come where after thrombectomy you give intra-arterial small dose of alteplase, the outcome seems to be much better.
yeah.
So there are a lot of trials to be done with tenectase also, especially a small dose of tenectase after thrombectomy, before thrombectomy. All those needs to be evaluated.
So that is immediately after you remove the clot and then give the drug.
Give a small dose of thrombolytic, so that all the small vessels which are not opened by thrombectomy will open.
Okay.
How much dose, Gigi? How much dose would you give?
20 milligram.
20.
So that is in
you've
the
already
trial.
given.
No. That is for what? That is with alteplase. TNK it has not been.
No, I know. But for alteplase, you've already given 0.9, and then on top of that, you would give 20.
No, the problem is most of the time when we take up for thrombectomy, the alteplase wouldn't be over. It's a 1 hour infusion.
Yeah.
So
but,
start the infusion
but
and
by the time you finish, it will be over. No, by the time you finish.
No,
So
it is a small trial which has come. It is not a random.
I know that you posted that trial also.
Yeah, right.
But I just wanted to know what dose you would use, because I'm a little scared.
I understood.
Should we use 5, 10, 20? How much should we use?
But we have not tried it. I'm just referring to that trial.
Arvind, you are muted. Yeah, you're muted.
For our interventionists, if he sometimes 24/7 they are not, and it is a large vessel, and so we always give bolus, and he never denies it, and take it for the intervention. So alteplase is given bolus, and he takes for the intervention.
Yeah. So there's another important aspect of TNK is, we just touched upon the current recommendation from the Government of India, Ministry of Health and Family Welfare is 3 hours. And when many centers have advanced imaging and like the extending beyond 3 hours, we just touched upon. But if there is an eligible patient and affordability and other issues are there, not ready for thrombectomy, in a situation like this, Dr. Arvind, would you consider giving TNK? Yeah, you're muted.
Muted again. So you are talking about 3 hours, right?
No, beyond 3 hours.
Extended.
With advanced imaging.
Yeah.
And,
see, Dr. Jairaj, it's a question which comes. So there are 2 things, that this drug is being used, and off-label is used a lot in India, and even many people have used more than me. And what in the groups when we discuss about the scientific evidence, what they get in their experience is really huge, and they benefited. But the only concern, even for the alteplase, is for the 9 hours, you should be very guarded about using it. When you are seeing by the flare, you take a wake-up study or the extend study where you have used by using the flare and diffusion mismatch, or you are doing a perfusion, right? If there is a mismatch, definitely the recommendation, most of them are the alteplase is being used. And as the tenectase is a promising drug, it will come. It is taking time, just like thrombectomy, which was at 2015, before that, where all the trials were like this. But I'm expecting it in the future trials. This is a promising drug right from the beginning, and it will be approved. What is my gut feeling says about it?
Yeah, thank you. So Dr. Ichaporia, what do you feel? Yeah.
Actually, there's no difference between the two. At least from what we have seen, there's no difference. See, the trials have to be done and it has to be proven. But the gut feeling is that it will work. I mean, that's the gut feeling, but we have to prove it. We have to show it that it does work. And unless we show it, it cannot be accepted by the rest of the world.
Yeah.
So, nobody believes in your gut feeling, or you've done 10 cases or 20. You have to do a proper trial. And unless you do it, publish it, peer review it, fight over it, nobody's going to accept it.
Jairaj, can I ask you a small doubt? Like we have the wake-up trial for TPA. Suppose if you want to extrapolate or do that for TNK, do we have to compare alteplase to TNK, or just study the effect of TNK in the wake-up trial patients?
We need to compare. Yeah, so that is what I think a couple of trials are addressing that, the unknown onset time. So we need to have head-to-head comparison, then only we'll be able to know. Yeah. So definitely for bridging, we have clear evidence, that it works in LVOs, and the similar thing, has to be done. That's why if we look at the timeline, the trial timelines, by end of this year or beginning of next year, we will have the answer for some of the questions that we are discussing here.
So especially to mention, Dr. Jairaj, what Dr. Gigi has asked, is the timeless. Timeless trial is addressing that part only, 4.5 hours to 24 hours. And they have good number of patients, as Andrew was saying, that will answer most of the questions they have used for Tenectase.
Yeah.
Is it a head-to-head trial, Arvind?
No, it is with placebo and Tenectase.
Acha, it's
And
placebo.
I used it because Michael was doing the wake-up trial at that time with Tenectase in 2009 when I was doing the fellowship. So at the time, I used almost in 15 patients. He has not published it. He has only published the initial part, right? Then something about the funding happened, but used in 15 patients in wake-up. And results were good at that time. 0.25 was used.
Well, one of the things which, that comes to my mind, and in the earlier years when TNK was introduced, and there was a steering committee which was created, and to have a phase 4 data, and DCGI had requested the company to come up with a phase 4 data. So that is a very crucial information, and I remember people started collecting information in the centers that were doing or using the TNK. There was a registry sort of thing that was happening, but I'm not sure. That is going to be a very good information, and if you are able to catch hold of that phase 4 data, and that will be, I think we would have crossed close to 5,000, 6,000 in the country.
That was the number which was given by DGCI even to collect that data for all the centers.
They wanted 2,000 patient phase 4 data.
Yeah, phase 4.
Phase 4.
That will be huge if India do that. They can be the master to tell the world about it.
Yeah. So now, before all the other countries come up by this year, we would have huge data. That is good. The prospective observational data, phase 4 data, and so I am not sure. I had encouraged few people.
Sir, it was 1,000 patient data. So we have already started. We have already started. Because of COVID, we have slightly slowed down, but it will be completed. So we have completed maybe 60-70%, whatever the requirement. So that will be, once done, it will be submitted to the DCGI. So it is ongoing, sir.
Yeah. So, if we are able to complete that, and that will be a very good information, our own Indian data, large data. Yeah, so there are a couple of other questions. Maybe one question, after that we will see whether we have any interesting questions from the audience. And so one is use of telestroke. A lot of us during the COVID, we have done different ways of contacting patients, being in touch with the patients, and including stroke. In terms of telestroke and thrombolysis, I just want to know your experience, and maybe you can start with Dr. Gigi.
Yeah, my experience in telestroke is very limited, so I don't think I'll be able to comment much on that.
Yeah,
because in most of the centers in and around our place, we have neurologists, so the scope for telestroke is much. In Kerala, it's much less. Yeah. So anybody else? No, Arvind?
Yeah, maybe.
I think you are the right person to comment on that.
No, telestroke, definitely. We started with especially we do it with the physicians where the neurologists are not there. And Mehsana is one of the model for us at Gujarat, where we do with 2 physicians the telestroke. But we try to develop the software which has been on the phone, which was not able. Then we use these modalities like WhatsApp, and but one center we tried with the phone. They transfer the 16 slice CT, and we decide on that. And the main concern for physician is what? The radiologist is not giving the report, right? It's still telestroke there. They have the problem of this. Once you consent them and you write a prescription and send it to them, please thrombolize this patient, then they started doing it. And we regularly do it with physicians. And it is a wonderful thing, right? It is not only the thrombolysis part, even to if they are doing the NIHS there are limitations in NIHS. And if you find to ship the patient by the airway corrections and the things which they say that what to do, the main question is, suppose they don't thrombolize there. And if the NIHS is more than 20, it's going to be most probably LBO, right? And they don't have a CT scan and we don't know its hemorrhage is there. So you can ask them to control the blood pressure, and it is within the window, they can send the patient to us. So that is also, televise is very important to maintain few things, which they are sometimes in concern that to be used or not. We put in the one of the CSCs, the labetalol and the drugs which are not there in those areas. Those are very important because when patient come to you, these factors matter, right? A super hyperglycemia, 500 sugar, 600 sugar, and the blood pressure 240, 150, 140. That is very detrimental every minute. We only talk about thrombolysis and thrombectomy. That is also important on the telestroke part.
Yeah. Dr. Chapter, you have any experience?
Yeah. We are using telestroke, of course, even internally. Now, I cannot be in the hospital all the time. So, we have our residents also. And we are using, if you can call that telestroke, it is in a way telestroke. But of course, outreach is very important. And there are a number of physicians. There are not so many neurologists. And what I really feel, if we want to take the stroke care ahead, we will have to train physicians. We cannot have so many neurologists. And even among the neurologists, we find that less than half are doing thrombolysis. So that is something, we must think about. So we must develop confidence in them. They are a little scared, they are a little diffident of doing it. So if there are experts around and who have done, experts, by experts, I mean people who have done many, and they can advise younger neurologists to take it up. And even physicians, I would say, encourage physicians to do it. And this really can give an explosion to stroke care in our country. And my only little concern is that what is the legal status of telestroke in our country? Is it the responsibility of the treating doctor, or is it the responsibility of the expert sitting and giving advice on telestroke? So where is the chain of control and how? So that is a little, always that worries me sometimes, who is really responsible for the patient? The treating doctor or the telestroker?
After the gadget, 25th March 2020, when the telemedicine was approved, right, in the gadget. So the advice, who is giving the advice is responsible. That is
the person giving the advice
is also responsible part for that treatment, what he is advising. Right.
Oh.
Right. That is important.
But Arvind Jairaj, there was some high court order that you should not give advice on WhatsApp. And you should not give. I mean, that really scared me, because all the time we are giving advice on WhatsApp. So I think this point has to be little clarified, huh?
The telemedicine rules, everything has come in place now. What sir was mentioning is before that. Now, just when the COVID started, the government of India published the telemedicine guidelines where it can be.
Yeah. So no, I was not aware. Thank you so much for enlightening me on that. So it is the responsibility of both, huh? Final, what is the answer? It's the responsibility of both.
Yeah, I think it's the responsibility of both, and there are clear guidelines the government of India has given, even for.
I better read those guidelines.
Telestroke also. Recently, with the NCDPR Bangalore, Dr. Padma was the chair of the committee, and they released the telestroke guidelines. So things are in place, and maybe it's not the typical telestroke where you have the app and different portals and
You don't need that. You don't need that. Why do you need all that? I mean, keep it simple, no?
Yeah, so there are some apps available, like we developed with ICMR support, and we are about to launch it, and then the COVID came, and so there's a lot of disruption. Dr. Dheeraj Khurana is for Chandigarh. Himachal Pradesh, with that urban spoke model, Dr. Padman developed. That particular group has created an app where they can identify the government stroke-ready hospitals in the app, and so they are also using. And there is another group which has come up with proper telestroke portal, and they are planning to do a cluster RCT. So that is at a large scale in different states, and so definitely, telestroke, not only during the COVID time, but also in other times when there are no neurologists. And so I'll just share our experience with Northeast India, where the ICMR has funded 2 MSUs in Tezpur and Dibrugarh. In Tezpur, there's no neurologist, and there are 2 hospitals. One hospital is affiliated to us, and another is the Tezpur Medical College Hospital, which is government. And through MSU deployment, we were able to streamline the stroke care, and they are getting calls for MSUs, but most of the patients are intracerebral hemorrhage. There are high rates of ICH there. But what we found was the thrombolysis rate has increased as compared to the pre-MSU time when we collected the baseline data. And after deployment of MSU, the thrombolysis rate in the hospital, in these 2 hospitals, it jumped to 3.5%, which is country average is about 2.5 to 3%. And and there the telestroke is built in. So they consult me, and I see the scans and advise them. And so as all of us agree that we need to really empower the physicians. Dr. Chaparia, you have done very well in your region, where the physicians are doing enormous amount of work in stroke care. And that is the way forward. Many of our ISA members and past presidents have really worked in this area and developed models for our country. And so now we have about 10 minutes left, and I just want to see if there are any questions from audience.
Jairaj, could you tell us a little more about these mobile stroke units and how they have functioned, and what was the cost, and what manpower is required, and a little bit more, because it's a very, very exciting project of yours. Really, I must congratulate you on having started it. I'm really very appreciative.
Thank you. Yeah. So the first MSU, we all know that COVID Medical Center, Dr. Matthew Cherian's group, they deployed, and they published their preliminary results in Journal of Stroke Medicine, ISA's official journal. So over about 2 years' time, they had about 13 calls, and they thrombolized about 7 patients, if I'm correct, from so what they have mentioned was you need to have government support. So this is what we are testing in Tezpur and Dibrugarh. So this project, I was working with the Baptist Christian Hospital for another ICMR work, and during the discussion, and ICMR has a lot of funds for developing research in Northeast India. So this idea of MSU came, the current DG, Dr. Balram Bhargava, and he said, why can't you write a proposal for MSU? So then I wrote a proposal, and so we thought we'll have it in 2 places. The first one was quickly approved. Both were approved, but the installation in government setup, it is in Dibrugarh, it took a lot of time. And so the cost is about, for the entire infrastructure, the mobile, the CT, and the ambulance infrastructure, it comes to about 6.5 crores. And you need to have 24/7, I would say, a toll-free number, or link it with 108 or 104. And you need to have at least 2 shifts or 3 shifts. You need to have at least 2 or 3 drivers, and one CT tech, and maybe a nurse. So this is what we have budgeted for manpower in these two centers. And so with this MSU, you have a point of care device. You can look at the PTINR. Somebody's on oral anticoagulation. The telestroke is built in, and a little bit of resuscitation tools and equipments are there. And what currently they are doing in both the places, they take this MSU and try to station it in a primary health center or CHCs and try to create awareness. With that, things are improving, and COVID really affected everything, but now it's picking up. Today also in Dibrugarh, there was a call for MSU to one hospital where the patient was there. So the entire team went and did the CT, and they decided on thrombolysis, but they wanted to stay back in the private hospital. So the thrombolysis decision was taken by the neurologist. Dibrugarh has a neurologist, the Assam Medical College, and he monitored the thrombolysis part. And so there are a lot of teething issues, but we are learning. And there are two more MSUs, one for Ludhiana and one for AIIMS New Delhi. It is in the final stages of approval. Hopefully, we will get Health Ministry's approval. So there are different challenges in India as compared to high-income countries.
But it's a good start.
Yeah.
But tell me, does the ambulance, when it's moving, can you do the scan, or it has to stop and then do the scan?
Yeah, they have to stop. Yeah, they have to stop.
They have to stop.
Okay. So what we have done is when we before starting the project, we map that entire area and look at the roads, because full of tea gardens in both the places. So we looked at how far the MSU could reach. So we have mapped the area and spots where MSUs can be stationed, and that is what they are using. And particularly in Tejpur, when we looked at the data recently, a lot of patients use the tea garden ambulances, because almost every tea garden has a small hospital, and they have tea garden ambulances. So they're creating awareness now with them. And with the Tejpur Medical College, about 40% of the patients, stroke patients, use 108 ambulance directly and came to that hospital. So now we are trying to integrate the 108 with MSU so that there is a proper coordination. So any questions from the audience?
Yes, sir. We have received. Sir.
Yes, sir. Most of the questions we have already addressed. Sir, one question is there regarding ICH. So, what is the risk of ICH with Tenectase compared vis-a-vis to Alteplase?
One of you want to answer, Dr. Arvind?
We publish.
We
publish our data in the 10-volt study where we analyzed all our patients. So our experience itself, it was published as the 10-volt study, Tenectase versus Alteplase. So the incidence was similar to what was seen in Alteplase. So there is no increased risk now. Actually, it is marginally less than Alteplase.
Yeah, I think Dr. Arvind,
Yeah, my feeling is stop comparing it.
Yeah.
Produce your own results, right? Tenectase, the way all the trials are coming, when it initially comes as a drug to be, there are antibiotics, right, which are used for the similar indication. So why not in stroke? We're waiting for a second drug, desmoterplase. I remember the trials, the TIAs. So different trials for different drugs. So alternative has to come, right? So if we do there is no need of head-to-head comparison when the drug is working, right?
Yeah, there are case series where the hemorrhage rates are lower. It's close to about 1.5 or 2% as compared to Alteplase. And I just reviewed two important papers. One from Australia, they had one regional stroke network. They, even though it is not approved in Australia, but they started using for convenience purpose, and New Zealand also. So the rates are comparable, and so in that way, it's probably slightly lesser than Alteplase, but it's comparable. And I don't know, I have not got hold of that ISC paper, which shows there is 50% detection from a large registry data. I've not read that abstract completely, but so I think more and more data is evolving, and by beginning of 23 or middle of 23, everything will be very clear. And any other questions? Yeah.
So there is a long history of a patient. I don't think so we will be able to take the history and the answer. But there's one important point come out of that history is that how can we, what is the caution one should exercise if the patient is already receiving antiplatelets while administering tenecteplase?
Yeah. So Dr. Chapuri, you want to address?
Yeah. Single antiplatelet, not increase risk of ICH. Dual antiplatelet, slightly increased risk, but it's not a contraindication. Yeah. You can use it. Anticoagulants, if the patient is on VKAs, that is warfarin or acetrom, if the INR is equal to or less than 1.7, you can use it. For NOACs, it's a little difficult. It depends on the time when the last dose was taken, the renal function. And if the patient is on dabigatran, you may be able to reverse it with the antidote and then give it. So these are the general principles. Yeah. Now, many times, unfortunately, we find that when the patient is transferred, he's given low molecular weight heparin and then transferred. And he's actually in the window period. And so now, should you give it or should you not give it? So the thing was that it is a therapeutic dose of anticoagulation. But now, he's just been given Clexane 1 hour before or half an hour before. So it becomes a little difficult, and I reject these patients. So we would encourage people not to give low molecular weight heparin before transferring the patient, because then, the whole thing becomes very difficult, and, we are scared that ICH may occur. So please refrain from that. But otherwise, what I have told you about the drugs, I think, stands.
Yeah, thank you.
That's it, sir. There's no further question.
No more comment. Yeah, I think we have covered a lot, and maybe I will go around and ask the panelists the final comments. One message, take-home message from all of you, and then I will I'll summarize and then hand over to the organizers. So we'll start with Dr. Arvind. One take-home message.
So thank you, Dr. Jaraj, for moderating it, and thank you, Emcure, for brought this topic of tenecteplase. So every drug has this time. This drug will also have its time. So we are waiting for the good results, and it is a good, promising drug, and we want to use it more and more, looking for more data.
Yeah, thank you. Dr. Chaporia.
Yeah, I would say that use whichever drug you're comfortable with. Both are equally good. See, the data is yet to come out. Okay. But as far as we know, both are good. Whichever you are comfortable with, use. Tenecteplase is also good. All these limitations are there, 3 hours and 4.5 hours. But I think it's okay up to 4.5 hours also. This is off the record, but this is what is written. It's only 3 hours, and it should be only given by a neurologist. Now that is also, we want stroke physicians to give it. So why should it be given only by a neurologist? So these things maybe the company can work on and make it more easy, make thrombolysis more easy for everyone. Less contraindications, less of 3 hours, 3.5 hours. It confuses everyone. So make it simple. That is my request.
Yeah, thank you. Dr. JJ.
Yeah, till 1996, we had only a tablet of aspirin which was effective. 1996, we got TPA. 2015, we got TNK in addition. Then we have mechanical thrombectomy also. So we have more, and initially we had only an AK-47. Now we have more methods by which the vessel can be opened. So we become more empowered in treating patients with stroke. So that's why I see it. So we need better drugs, better techniques, better devices, so that these unfortunate patients will benefit from this.
Yeah. Thank you. So I'll just summarize. Thank you very much. We had a lovely discussion, and definitely in India currently, up to 3 hours it has been approved, and more data is in pipeline. And I think by, as I mentioned earlier, that by 23, we will have a clear answer, and more patients will benefit. And so with that, I'll conclude, and I'll hand over to Dr. Sanket Niwale and Dr. Onkar Swami.
Thank you, sir. Thank you. I'll thank Jairaj sir for your expert and excellent moderation. I thank our panelists, Dr. Ichhapuria, Dr. Arvind sir, and Dr. Gigi sir for their expert comments. I believe the journey of Tenectase has started long, from the global landscape to the Indian landscape to the now coming the studies with from the times of to 3.5 hours to now. It might, as we see in the WHO as well, up to 9 hours and so. So I think the ongoing trials will open up more or rather increase the confidence of the prescribers for the molecule Tenectase, and more people would be able to get thrombolyzed on an earlier scale and have better outcomes. With that note, sir, probably in the coming future, we meet again for another exciting session when new evidences would come out and a new experience sharing would take place. So until then, I thank each and every one of you for sparing your time for the meeting. Thank you all.
Thank you.
Thank you.
Thank you.
Thank you.
Thank you.
Thank you. Bye.
Sir, Ichhapuri sir.
Yeah,
one point which I wanted to, suppose if you use a dedicated platform for telestroke, documentation is much better. Like all the details are stored in that dedicated platform. The problem with using WhatsApp is you don't have a backup of that. So, or you should specifically backup if there's the video should be recorded, should be stored, all the communication should be stored. The advantage of having a dedicated telestroke platform like an app or everything gets recorded, especially the video of the patient is very. So what we usually do is we ask the other hospital to take a video of the patient and send it through WhatsApp, and we save that video. And the conversation also, we try to keep it as a record.
Recording stopped.
okay. Yes, thank you.